First of all, let's talk about the surveying. When the first time you hear survey or surveying, you might think about this regularly. You saw some people stand over a road and measure the length of a road. However, in the dental practice, the surveying means to analyze and compare the prominence of intraoral contour associated with fabrication of a dental prosthesis. So basically, you can think about that the surveying is to talk about how to measure the height of contour. And the dental surveyor is an instrument to help you to do a surveying. So what a height contour means? So if you saw a tooth and then you have a specific passive insertion, then you will find out some part of the tooth can contact with that line. And if you contact all the line or point together, you will measure a line, and that will be the height contour of the tooth. And why we need to know height contour for our RPD project? Because we need to know where is the undercut. The reason why we need to know where is the undercut because we need to use the undercut to make sure that your RPD framework and the RPD itself can be held by the tooth. So why we need surveying? Because we need to determine the most desirable path of placement that will eliminate or minimize interference to place or remove the removable partial dentures. The pace of the placement means that the directions you can put the prosthesis in and out of the tooth or the oral environments. So why we talk about the desired path of placement? Because you can always change the pace of placement. And when you change the pace of placement, you also change the height contour. Look at these pictures. If you put the egg over a surveyor, the first beginning you can mark a survey line or the height contour in the yellow line. However, when you tilt to a specific angles, then the height contour of the survey line will change to the blue one, not the yellow one. So eventually you will have thousands of passive placements or thousands of height contour, and then you have to record it, what you really want. That's why we need the surveyor. The surveyor is the tool that can make you determine where is the desired height contour. Also, you can record it on the cast. So you can see here the surveyor actually included two parts. One is the surveyor itself, the other is the surveyor table. The surveyor table allow you to change the angulations. However, finally, you can use the surveyor arm because they are fixed. So eventually, you will be fixed into one path of placement. Also, you need to know what's the purpose to use the surveyor. You can see those are the reason why we use a surveyor. However, nowadays, as a dentist, we usually just use the surveyor to do the first three or four purpose, and the others are usually used by the lab technicians to fabricate the framework. Over the market, you can see multiple surveyor be available. However, the knee surveyor is the most common surveyor you're gonna use, and we will also use this in the UDM school. So the surveyor itself actually, like I said, included the surveyor and the survey tables. And we will explain those details in the scene lab. Also, you are gonna use some styluses for the dental surveying. So you will have 6 different instruments which you're gonna use. However, for most of the surveying procedure you're gonna use, regularly you will just use A, the carbon marker in the metal sheets, and CDE is the undercut gauge with a different size of undercut. You will also use the analyzing rod like F is showed. The B, the wax knife, basically was just used by the technician. So like we mentioned earlier, we want to find out the hive contour. So that's why we use a surveyor. The reason why we need to know hive contour because we need to know where is the undercut. That's why you're gonna use the undercut gauge to determine where is a proper undercut. And we have 3 different undercut gauge to provide the different size of the undercut. When you see here, when the undercut becomes greater, that means that the undercut location is more close to free drawn margins and also can provide more retentions. So look at these pictures. So we know the red line is the hive contour and the green area is the undercut. So when you use 0.01 inch gauge, when you use the undercut gauge and make the shank of the undercut gauge touch the tooth, when you move it up, when this undercut gauge be stopped by the tooth, this pink area actually is 0.01 inch undercut. If you use 0.03 inch gauge, you can see that distance is more wider. And when you move up, it will be stopped more close to the free drawn margins. So this area will be called 0.03 inch undercut. That's why we said when the undercut becomes greater, actually the location is close to free drawn margin and provide more retentions. Okay, now let's talk about the purpose of the surveyor. So first of all, we can use the surveyor to do the surveying the diagnostic cast. Actually, we have 4 steps for the surveying of a diagnostic cast. The first, you have to identify the most favorable tilt. Means that you have determined the favorable path of placement. And then second will be tripod the cast. Third will be place the survey line. The last will be located and marked undercut. So let's talk about the path of placement first. So when you remember that we said the surveyor have the surveyor and the surveying table. The surveying table is adjustable. So actually you can create numbers of potential paths of placements over your object. Just remember that egg. If you tilt into a different angle, the path of placement or the hive contour line actually changed. So what's the desired path of placement will be? So when we do the treatment planning, the cast, then our advice is you probably doesn't want to tilt the cast over 15 degrees, followed by the occlusal plane. And just remember, this tilt or this angles is referred to the relationship of the plane of occlusions, not the tilt of the surveying tables. Because sometimes the base of the cast may be is not really parallel to the floor or to the plane of occlusions. So you just need to follow the remaining teeth to determine the plane of occlusions, and then you want, when you tilt your surveying table, to find out the desired path of placement not over 15 degrees. Why we shouldn't tilt the cast too much? Because when we tilt the cast too much, then you will probably make patient very hard to seat or remove the removable partial dentures out of the mouth. So let's take a look first. So when we want to place this removable partial dentures over the tooth and the ridge, if we determine it followed by the occlusal plan, it will be easier to come in and out. However, if we change this angulation a little bit tilt and maybe over 15 degrees, what happens? When patient want to place this removable partial denture over the tooth and ridge, first of all, the direction have to be in, and then this removable partial denture need to turn back to the original angles, then it can be seated over ridge. So when you take it out, it's the same. It will become like a curve. So it means that when you able to find your desired path of placement between 0 to 15 degrees tilt, this range will allow patient easy to handle the prosthesis in the mouth. Any tilt or angle greater than 15 degrees means that the prosthesis need to be inserted at an awkward orientation in the mouth. And this probably will not prevent over-reductions of the tooth structures and also will produce unaesthetic result and possibly pulp exposed. So here we will talk the other term the first time you hear in the removable partial denture, the guiding plan. What's a guiding plan means? The guiding plan actually is the prepared proximal tooth surface which are parallel to one the others, and their function is to act to define a path of placement, to contribute the stabilities and be sure the clasp action can be active. In simple, you just need to think about why we call it guiding plan. So it's a plan that used to guide something. And why we need this? Because this plan is to help the patient can guide the placement of the removable partial dentures into the mouth. And here you see that the slide that the guiding plan guide proximal plates of the removable partial denture into a predetermined path of insertion. So what's the proximal plate mean? Remember in the past we talked about rest and rest seat. We said the rest is on the framework, the rest seat is the prepared surface over the tooth. So guiding plane and the proximal plate are the same. The guiding plane is the surface you prep over the tooth. The proximal plate is a component on the removable partial denture framework. So basically this guiding plan is be sure that when your partial denture be seated, those proximal plate can follow that guiding plan to be seated. So the issue will be how can you establish appropriate guiding plan? When we need to do a guiding plan, basically means that you're gonna prep the proximal surface of the tooth. And look at the diagram A. is that it shows uneven distribution of an undercut, resulting in more reduction to the molar than the premolar. So you can see when you have a desired path of placements drawn by the yellow line, you can see the premolar seems pretty follow that directions. However, if you look at the molar, it doesn't really follow that. That means that you have to prep it and create a desired guiding plan. That means that you have to reduce a proximal of the molar and to get that. However, if you see the diagram B, if you tilt to some degree, then eventually that you don't really need to reduce a lot on the molar. You can distribute the grinding on the premolar and the molar to get a desired path of placement. So you don't want to just only prep just only on the tooth. You want to distribute that the adjustment over the others. So eventually you don't want to over reduce some of the tooth's proximal plate. And what's the dimension requirement for the guiding plan? As long as the occlusal 1/3 to 1/2 of a proximal surface is parallel, that will be available for the guiding plan. There's no need to prepare the entire proximal surface of the tooth to have an appropriate guiding plan. So just remember the number. The occlusal 1/3 to 1/2 of the proximal surface height is available. Okay, so we already talked about why we need to use the surveyor to do a diagnosis. And the other purpose is to eliminate the hard and soft tissue interference. Because sometimes if we have a huge soft tissue undercut, it might not desirable for the fit of a component such as gingival approaching clasp. And what's a gingival approaching clasp means? Remember we talked the I-bar in the sim lab. I said the I-bar because it looks like an I word. Also, it has a bar type. That's why we call this clasp. It's I-bar. And you can see its direction actually is from the gingiva toward to the occlusal. That's why it was called gingivally approaching clasp. So when you design this kind of clasp, you don't want to have a huge tissue undercut because this I-bar or the other gingivally approaching clasp is not able to engage into the undercut. If you engage into the tissue undercut, then you are not able to seat it or take it out extraordinarily. Also, we want to use the surveyor to provide suitable undercuts or retentions. So what's a suitable undercut or retention means? Actually, this depends on the different type of a clasp. When we use a metal to do a casting clasp, because it was made by the metal, so it's more rigid, so you don't need a lot of undercut. You just require only 0.01 inch undercut that will be available. However, sometimes we will design a roll wire clasp. The roll wire clasp means that you use some wire then to just bend it into a desired shape. So you can see that the wire is more thin and more flexible. So if you want to get the same retention as the casting clasp, you definitely will need more undercut. That's why here you can see the roll wire clasp require 0.02 inch undercut. So you have to know the 0.01 undercut for casting clasp is provide the same retention for 0.02 inch undercut for roll wire clasp. However, we just say we have three different undercut gauge. We have 0.01, we have 0.02, we also have 0.03. Nowadays, we are no longer use 0.03 undercut gauge because it's too deep and too retentive. Just the reason why we use 0.03 in the past, just because sometimes we use the pure gold to do casting. However, nowadays we no longer use the pure gold to do a casting procedure. So you no longer need the 0.03 undercut gauge. So we already talked about the first purpose of a surveying, to identify the most favorable tilt, the path of the placement. Because we want to establish a appropriate guiding plan, we want to provide suitable undercut and retention. We also want to eliminate the hard and soft tissue interference. The final purpose is to create the desirable aesthetic. So after you finish that, then the following step will be do the tripoding. So why we need tripoding? Remember, after you finish your surveying, you already determine the desired pace of placement. And you also remember that the surveying table can be adjustable. So how can be sure that you already determine the desired pace of placement, and when you take those casts out of surveying table, when you put it back, you can repeat it. So you have to record this relationship as a future reference. So once you get this record, actually anybody with the same surveyor can use those markers to reduplicate those desired paths of placement anytime. So you can do your surveying and do the tripoding. Then you can send a cast to the lab, and the lab technician can use the same way to find out what you want for them to design or to fabricate the RPD framework. So the tripoding procedure, actually, first you have to fix the aligning rod in position with that you desire to have. And then you will use that to mark three wide divergent points on the cast with the pencils. You just need to remember that once you mark those 3 points, you don't want to lift your analyzing rod. So eventually you will get 3 different points on the same height. And we said 2 points you mark a line, 3 points you have a plan. So eventually you kind of like create a plan records over the cast. And when you mark those 3 points, in the sim lab, we will talk about how to mark it. But desirely is to circle with the red pencils for identifications. And we will explain later in the sim lab to say why we need to use a red pencil to mark this. And when we determine the 3 different divergence points, that the ideal or the preferable location is that we don't want those points to be placed on area of the cast will involve into the framework design. We also want those points can have at least 1 inch apart on lingual vertical surface. However, sometimes it's very hard for us to place those 3 points on desired locations. So the alternative way is that you can use the grooving method. So you also use the same analyzing rod, you just put it on the side of the cast and then to carve 3 lines or the 3 grooves over your cast. That's the other way you can do that. However, we will still like you to do a tripoding because they'll be more clear or not easier to be destroyed during the procedure. Okay, so after tripoding, then the third step is to place the survey line. So what the survey line means? Actually, when you use the surveyor, then with the carbon markers attached, and you go around the tooth, actually you can mark the height of a contour. And finally, you can connect all the points into a line. And this line is called the survey line. So basically, you can say actually the survey line is the height contour of the tubes. They are the same. The difference just only because the survey line is the line that you use the surveyor with the carbon marker to mark. And let me remind you again, the reason why we want to use the surveyor is because we want to find out the height of a contour, and then we can find out the desired undercut. So the surveyor line actually to talk or to record the height of contour, and eventually will easier to communicate with the other peoples. And here you can see on the slide, it said if the undercut is too little, too large, or too high or too low, then you can readjust the angle of the table first. But remember that in the first step, we already find out our desired path of placement. If you change those angle again, actually you will create the new height contour. You will create the new path of placement. So what if when you find out a good path of placement, but the undercut is still not in the ideal location? How can you do that? So either you have to recontour the tooth by like enamelplasty or to add a composite, or you have to make a crown. The crown you make followed by the survey line design is called the survey crown. So if everything looks fine, then you will locate and mark the undercut locations. So you will attach the desired undercut gauge followed by your class design. And then you adapt the shank of the gauge against the tooth of surface and raise the spindle until the bottom foot contact the tooth. That area will be your desired undercut position, and you will mark with the red pencil as the picture shows. So let's see how you do it. So remember, you use the undercut gauge followed by the clasp design. The 0.01 inch undercut gauge is for casting clasp. So if you touch the shank, if you move it up, when the bottom just right away touch the tooth, that point is the 0.01 inch undercut into your desired position. So you have to mark it with a red pencil. And we will practice this when we in the sim lab. Just to remind you again, so the desired undercut, the casting clasp is 0.01 inch. The roll wire clasp is 0.02 inch. So after that, you already finished all the steps to do the diagnostic cast surveying. Then it will be the time to design the RPD framework, and we will discuss that in the sim lab. Okay, so you must remember that I said you have 3 to 4 purposes of a surveyor you're gonna use, be as a dentist. So you already know how to survey the diagnostic cast. You already know how to recontour abutment tools on the diagnostic cast. You also know how to measure a specific depth of the undercut. So final step or final purpose is to surveyed and broken out the master cast. But before we discuss surveying master cast, let's talk about mouse preparation first. Remember this flowchart I showed you in the SynLab. So right now you already know how to do a diagnostic cast, how to do a faceable transfer, and mounting on articulator. And today our topic already involved into how to use the surveyor to do the diagnostic cast surveying and tripoding. So the next step actually is to do a mouse preparation. Mouse preparations. So the mouse preparations need to follow the preliminary diagnosis and by your tentative treatment plan. So basically it means that you want to, after you have a desired treatment plan and desired removable partial denture framework design, then you have to be sure that the oral environment can befit those design. If it's not, then you have to do some preparation work to be sure that the oral environment is desirable. So those mouse preparation actually include into 6 different categories. The first is oral surgical preparation. The second will be the conditioning of abused and irritated tissue. Then will be followed perio, endo, also preparation. The final one is to preparations of abutment tools. So why we need the oral surgical preparation? Because sometimes if a tooth is not healthy enough, then you might need to extract the teeth out. Some tooths may be malposed because of the mixing teeth. Then you might need to remove that because they are not able to fit with your RPD framework design. When patient lost the tooth for a long time, sometimes like tuberosity may be enlarged overgrowth, then you won't have enough enlarged space to accommodate the removable partial denture. So you have to ask for tuberosity reductions. Sometimes the tissue will overgrow, so if patient have a hyperplastic tissue, also need to do the surgical procedure to change that. Some patient might have a high muscle or frenulum attachment affect your boulder seal, then you also need to do the surgical preparations. The last will be some patient lost the tooth for a long time, the ridge already resorpted into a knife edge, then you want to use a surgical procedure to broaden it. Some patient might also have some like deformative or some cyst, even a tumor, then you also need to remove that before you proceed to the framework fabrication. Some patients might wear the original prosthesis for a long time. And remember, because the ridge was resorpted, so the worst prosthesis sometimes is ill-fitting. And when patients wear the ill-fitting prosthesis for a long term, it was easier to see the mucosa were easier to get inflammation and irritation because the denture is not stable. It also will, some patients will have some burning sensations over residual ridge area all the time, even will involve into the cheeks or the lips. The normally sign you will see over the clinic is that you will see a redness or ulcerations over the soft tissue. So if patients have those conditions, first of all, you have to be sure you can get rid of that. And how can you do that? So you have to do the conditioning. The conditioning procedure should be repeated until the tissue is be healthy. And how can you do the tissue conditioning? So you have to use tissue conditioning material, which in the school we usually use called soft. It's a soft material that can fill the space. So first of all, it can create the fitness of existing removable partial denture over ridge. The second, because this is a soft material, so it will not provide or give too much force or pressure over the tissue, so the tissue can be rest and can be healed. And how do you use that? So many dentists find that the intervals of 4 to 7 days between change of the conditioning material are clinically acceptable. So basically in the school that you would place a console first, adjust it, then you will send patient back home and make appointment maybe after a week and come back and to replace a new one. So you will continue doing those until you see the tissue is healed. However, the positive result should be seen within 3 to 4 weeks because that's the period that the tissue healings need. If after 4 weeks you haven't seen the tissue be really healed well, then you might need to suspect that patient has some more serious health problems and you need to have consultations from the physician. For example, if patient have uncontrolled diabetes, then patient will have a high blood glucose ratio that will delay the tissue healing. So first of all, you have to ask patient to control the diabetes first before you do a tissue conditioning procedure. Some problem is from the perio. For example, if patient doesn't really clean the tooth well, have a lot of calculus, have a lot of inflamed tissues, then you have to do the periodontal control procedure. So the purpose of this one is that you want finally the tooth will be healthy. Some patients might have some endodontic problems, for example, non-vital teeth, or some patients have a severe worn out tooth to cause pulp exposure, then you have to do endo treatments. And remember, when patient lost a tooth and didn't restore it right away, then you might cause some teeth mesial tilt or migration. And if that tooth is not in the proper locations, either they might affect your design of a the path of placement, or you might not able to use that as a abutment. If that really happens, then you will need to ask the patient to do orthodontic treatment if you still want to save the tooth and use the tooth. And the other issue will be sometimes the tooth will over erupted and create an improper occlusal plan. So in those circumstances, either you ask patient to extract those teeth out, or you might need to do also treatment to intrude those over erupted tooths. The last step is to do preparation of abutment tooths. So when you have your tentative RPD design, then you will have those location of the undercut. And you also need to create a guiding plan. So if your tooth morphology is not really follow those, then you have to prep the tooth. So here you said, so the preparation of the abutment tools actually need to follow by your tentative RPD framework design. Also, you have to follow those component dimension requirements. And we will discuss those dimension requirements in the SynLab. You will now eventually to know how to choose appropriate burr and how to create the appropriate dimension requirement for each different RPD component. So let's talk about the final purpose you're going to use for the surveyor is to do a surveying over the master cast. And why we need to use the surveying for the master cast? Because remember we just talked about when you finish your surveying of a diagnostic cast, you create the desired path of placement for the patient. And then you have to go through all the mouth preparation procedure to be sure that the entire oral environment, including soft and hard tissue and the tooth, can be fit with your design. Then you take the final impression for the master cast. But before you send the master cast to the lab technicians, you have to verify again. Because sometimes maybe you want to design an undercut in some specific location, but after you prep, you might lose it or your preparation is not really accurate. That's why you still need to do a surveying on your master cast again. So you want to align the guide plans you already prepared, then identify and mark the desired undercut area. Ideally is that those undercut locations, those guiding plans, dimensions, and alignment are the same as the diagnostic cast. If it's not, you might need to see if you need to do some modification of your design or try to see how you can correct that. Later on, you will need to tripod the master cast and send the master cast to the lab so lab technician can follow your design to do the framework. Here, the only difference when you do a surveying diagnostic cast and the master cast is that you do not mark survey line on master cast. You just only mark the tripod points and the desired undercut mark on the master cast. The reason is that because the lab technician will need to use the wax to do a wax up for the framework and then to do a casting. And those carbons marker you transfer by the surveyor is easier to inhibit the flow of the metal in those areas during casting. For these reasons, so you want to eliminate the marker on the cast. So you just need to remember, you just need to mark the tripod marker and the desired undercut locations on your master cast without mark the survey line or the other framework design. Those will be just mark or draw on the diagnostic cast.